Hello and welcome to the second summer event of the Cycle Technologies EduSeries. This is Ann Mullen speaking from Cycle Technologies in Washington, D.C. I will be your host for the webinar. Today's topic is fertility literacy and specifically the relationship between fertility health and overall health. But before we get started, and before I introduce my guest, I'd like to mention a few technical items. First, I'd like you to be aware that the webinar is being recorded for future viewing. Second, you, our audience, are muted, so we cannot hear you, and you cannot hear each other. And finally, if you didn't get the chance to send in any questions before the webinar, you can send us questions during the webinar. There should be a question box on the right-hand side of your screen in the webinar panel there, and just click submit, and we'll get to your questions as we have time at the end of the interview. The presentation should be about 30 minutes. We'll try to keep to that deadline, and we'll take about 10 to 15 minutes afterward for Q&A. So I am happy to be joined today by my guest in St. Louis, Dr. Mary Lee Barron, professor and family nurse practitioner, who has just retired this year from St. Louis University. She has extensive experience as a family nurse practitioner, and in addition, she specialized in fertility literacy and also natural family planning. At St. Louis University, she was the director of the Nursing Center for Fertility Education for 12 years. So welcome, Dr. Barron, and thank you for joining me today.
Thank you, Ann. It's a pleasure to be with you.
Now, I know you have a number of qualifications, and I've just listed several, but is there anything else you'd like to add? I think you have some things coming up in the future.
You've explained my initials. I'm a Marquette method natural family planning educator. I've done quite a bit of research with Marquette natural family planning. And I'm also in OBGYN. I practice in a clinic for Spanish immigrants right now. Doing a little bit of gynecology, and I'm going to go ahead and teach for Southern Illinois University at Edwardsville. So my academic career isn't really over.
So yeah, even though you retired, it sounds like you'll be busier than ever.
Yeah, well, not busier than ever because I was in administration, so I'm taking a regular faculty position.
Okay, well, I'm glad that you had the time to join us today. I read your articles on fertility literacy that were published in the Journal for Nurse Practitioners, and I found them not only interesting but also sometimes surprising. So I've put together some points from your articles so that we could discuss them, I could ask you questions, and we could talk about them for our audience. And first, before we actually talk about what fertility literacy is, we have a mixed audience today of healthcare providers and also persons simply interested in fertility literacy. So I'm going to try to launch a poll here for our audience to take. What we'd like to know is how you're interested or why you're interested in fertility literacy, and maybe that is showing up now on the screens. If you're a healthcare provider, could you please, select the first one. If you're a student who's majoring in a healthcare area, there's the second one. But if you're not a healthcare provider, please select one of the last three. It looks like almost everyone has selected. So it looks like most of our audience are healthcare providers, and we have a number of other people who are interested in them for themselves, so information for themselves. So we'll keep that in mind when we're discussing our points. Now, I would like to just put up here what I took from your articles to be what fertility literacy is. Does this look about right to you, Dr. Barron?
It does. Do you mind if I add a comment before we launch into fertility literacy? I'd like to share with the audience why I got interested in this. And the reason was I had done a lot of work with preconception counseling early in my career and had always made that a part of my natural family planning practice. And I had counseled a woman about her preconception factors, And the husband looked at me and he said, well, now what about me?
Oh.
And I really didn't have a lot of information at my fingertips to share with him. So I began to investigate that. And it was also with the idea that we treat fertility like a disease. And we treat it like a disease until we need it. And then it becomes much more important to us. And I really think that being in natural family planning and seeing fertility as a gift so fertility literacy was really about fertility health, and so now if we go on, we can make those connections for the audience.
Well, no, I'm really glad to hear that, because I was, reading the articles, and it did seem like this should be general knowledge, but it just doesn't really seem to be general knowledge, and so I was curious as to how you came upon to be the one to start putting this together. And I did notice, so for understanding fertility information, not just the biological symptoms, but you have also how lifestyle affects fertility, and knowing actually how to get services if you have a problem or questions. Is that like part of your goal in fertility literacy education?
Oh, absolutely. Absolutely. And I would like to see that men and women make the connection earlier rather than later about how their fertility health is related to their health later on in life.
Well, and that's another thing I found, that, it seems pretty obvious that fertility literacy would be about reproductive health and pregnancy outcomes as well. But I like that you took this next step that goes into overall health and disease prevention. How is it that you came upon that?
Well, when I was doing my dissertation, I did my dissertation on the menstrual cycle and pregnancy and health. And I learned a lot about the importance of the menstrual cycle, and that women who have irregular cycles are also the same women that develop cardiac and metabolic disease, i.e. diabetes, later on in life. And so that you should never ignore those irregular cycles that occur early, particularly with teens. And so when I began to investigate the men, the same idea held true. Men who had problems with the quality of their semen, their sperm counts, were also those same men that developed cardiac and metabolic disease later in life. So here's the paradigm. It holds true for men and women. And I don't think that we think about that quite that way. And certainly among the men do not know much about their own fertility. So when I teach natural family planning now, I always make a point, and the guys are absolutely fascinated because nobody's ever talked to them about it before.
Well, it's interesting you should say that, because in my next point, I was fascinated with all the information on men. So here I have men reproductive health as a marker for their overall health. And I mean, it is a bit unusual. When you think of reproductive health, you're usually talking about the woman and her issues. And also, the other thing, it seems like men are notorious for not even going to regular checkups. How is it that you get men in to talk about these?
Well, you catch them at a primary care visit. And I aimed my articles actually in primary care and tried to make it so that practitioners would understand that this doesn't take a lot of extra time to talk about, because they're going to talk to a man about, if, for example, if a man is 20 pounds overweight, his risk of infertility increases by 10%. And of course, being overweight isn't good for your cardiovascular system. And also, interestingly, the issue of testosterone deficiency is coming up. You're seeing more articles about that, and so the men who have low testosterone are also the men who have insulin resistance, obesity, abnormal cholesterol counts, and they also develop hypertension.
Well, you're covering the points that I did find.
I'm sorry.
No, not at all. I just mean those are exactly the things that I wanted to ask you about. You talked about semen quality and sperm counts. I wasn't exactly sure what you meant by surrogate measure, but I think that what you're saying is that when you see those values, it can tell you about a different kind of risk. Is that right?
Mm-hmm. That's correct.
And then you also talked about the modifiable risks. So you just mentioned weight. That's something someone could do something about, and it can affect the outcome then of chronic disease. And also fertility health. Is that right?
That is right. And of course, we're seeing a lot more obesity in the United States.
So that sounds like that we could see also more problems with fertility. Do you think that that might happen?
Oh, I absolutely think that's going to happen. I do.
Well, in these certain conditions, so you use those as a marker, and then you also mention the medical conditions then that affect fertility, and specific to that seemed most prominent were the reproductive conditions, and then you talk a lot about cardiovascular function.
Mm-hmm. That's right. And so if you want to get a young man's attention, and I'm going to be kind of blunt about this, if you tell him he's a candidate to get erectile dysfunction later in life, you will catch his attention.
His ears will perk up.
That's correct. And so, it is, I've always gone by the philosophy of you meet people where they're at. So as a healthcare person, I'm going to address those issues that I think are going to get a patient's attention first, and then I'm going to go on to other things to promote health.
And so when you talk about the reproductive conditions, so we listed a few of them here. I assume that these show up maybe at a preconception, maybe when he's married then and is thinking about it. Do these things come up, or do these actually come up in primary care?
Oh, they come up in primary care.
Mm-hmm.
A varicocele is like having varicose veins in the scrotum.
Okay.
And so if you were to do a physical, you might note that. It's a common reason for infertility. The man might not choose to do anything about it until he's faced with the issue of wanting to become a father, or he might choose to fix it, get it fixed then. Unfortunately, we do see young men with sexually transmitted infections, and then epididymitis is a result of having an STI. So there are behaviors that you talk about with people when you encounter that.
Mm-hmm, mm-hmm. And then the relation of cardiovascular function to fertility. I mean, you mentioned erectile dysfunction. Is that then a marker for these other? Mm-hmm.
Erectile dysfunction is a marker for later cardiovascular disease.
So it may not be apparent at that moment, but you could warn the person to say you could be developing something.
You promote you take the positive approach here about promoting those behaviors that will give him good fertility health, but also decreases risk for these issues later on.
Okay, well, I won't spend too much time on each of these because you mentioned so many interesting things, and I have a number of them I'd like to make sure we cover in our time. But one of the things that you talk about are non-modifiable risks, so things that a man can't do much about. I mean, one is his age. So you mentioned some interesting statistics. If maybe you could explain a little bit about how age affects men and their fertility.
Well, age 35 seems to be statistically the age where fertility begins to decline, and it is true for men and women. Although men are going to produce sperm through their entire life, but their ability to father children does decrease, even as we have more men in older age groups choosing to father children. The age increasing in the 50 to 54-year-olds and 60-year-olds. So
they kind of skip over the upper 50s or the late 50s.
Well, yeah. Well, you still have men who are, in their late 30s and early 40s, increasing too, but that number is increasing by 25%. But what's remarkable is that you would have men who are 50 to 54 and 60 plus wanting to become fathers.
And yeah, that's an interesting point about, women. We're often told as women after age 35 your fertility starts to go down, but it doesn't seem like that's so awareness among men. You talked about a couple other things that you can't do too much about, and specifically you mentioned medications.
Yes, as a man ages, he's more likely to have chronic disease occur, like hypertension, diabetes, and what have you. Now, he's able to manage his disease, but medications that are used to manage those diseases will affect, some medications will affect sperm count and quality. And then chronic disease in and of itself is going to affect your fertility. For example, diabetes is notorious for affecting a man's fertility.
All right, so for the healthcare providers, that's something to keep in mind when they're coming to their primary care visits. And then you talk about the modifiable risk factors, and I've called them lifestyle factors here because it seems like, it does have to do with lifestyle, and I put together a couple different categories. The first one I have here is body and behavior, and you were just talking about a man's weight, and here I have a BMI. So that was interesting. You said if a man is 20 pounds overweight, his fertility goes down by 10%, was that right?
No, his infertility increases 10% for every 20 pounds that he's overweight.
Oh, so it's additive.
Right. And it could be that the man who is obese has higher scrotal temperatures, and that's going to have an adverse effect on his ability to make sperm.
So it looks like all these things can go together. Stress, I don't know if that has any specific outcomes as far as quality of sperm and so on, but certainly exercise and body mass index would be related with it.
Well, stress, the older studies indicated that stress negatively was associated with measures in the semen. We don't have any good recent studies that suggest that. But in any case, stress, psychological stress, can reduce the sperm density, the motility, and even the number of abnormal sperm will increase in that event. And so part of good health, I think, is talking to patients about how they manage their stress. And if exercise is one of those ways that they manage it, that's great. Men do need to be careful about the type of exercise that they do, in that they need to, of course, wear protective gear. The one that's probably most concerning are the guys who ride the bikes with the Lycra suits.
Right, yeah. No, I have a friend, and they had much trouble conceiving because he was a racer, and it took quite a while for them.
And that's sheer temperature increase with that.
Oh, and that's temperature, so it's not like any kind of damage to the testicles.
If a man has a really intense exercise, like a Olympic swimmer or something on that order, they produce high levels of adrenal steroid hormones that can then in turn trigger testosterone deficiency. But that isn't the guy coming in for primary care for the most part.
Right.
This isn't the average male.
What about like daily stress or work stress? Is that also included in the stress category as far as fertility is concerned?
I think that stress always has its effect. Chronic stress does have an effect on health. Have I seen a study that demonstrated that in particular? No, I have not.
Not yet. Another category that you mentioned and had quite a bit of detail about was chemical exposures or chemical substances, and some of them are like intake, smoking, marijuana, alcohol, caffeine. Are any of these significantly harmful to a man's fertility?
Well, I don't have anything good to say about smoking. I mean, in terms of health, in terms of fertility, for men or women, I have nothing good to say about it. But in men in particular, show a 13 to plus to about 17% decline in their sperm counts, and that was done over a series of 20 studies, so it's well documented. Marijuana in particular can reduce testosterone production, the sperm count, the semen quality. And there was a pediatrician researcher years ago, back in the 90s. His name was Ira Chasnoff. And he did a study where he took the rats and he put them under a hood and forced them to smoke marijuana. And what was interesting about Chasnoff's work is that those rats then produced high percentages of abnormal sperm. But it wasn't just that generation of rats that did that, because their offspring, the next generation, who were not exposed to marijuana, also produced abnormal sperm, and then the generation beyond that, so even the grandchildren.
Oh, that's interesting.
So,
have they shown anything in humans that way, or is it?
Well, no, I haven't seen any human studies, but I am very cautious when it comes to the idea that marijuana is benign. Yeah, I don't find it benign at all for men or women.
Right, and of course we're going through a bit of a wave of legalization in the U.S., so that might not. Yes. So it might be some information someone may, would like to have made more public.
They could study people who live in Colorado, you know.
There you go.
Or Washington now, I guess.
Yes, for your next research paper. And then finally, caffeine. I'm curious about this one for men and for women with Starbucks and all of that being so trendy. And does caffeine have much to do with fertility?
Well, there isn't a lot out there about caffeine, but because it's hard to separate caffeine from alcohol and smoking in the studies. But in Denmark, they did do a study on young men, and these men consumed about two 16-ounce bottles of cola a day. They took in at least 800 milligrams of caffeine a day, and that two 16-ounce bottles a day was associated with reduced sperm concentrations and the sperm counts. It was particular to cola, which is very interesting.
So not like Mountain Dew or coffee.
No, it was the cola, which I thought was kind of interesting.
Maybe there's something about that.
So it's something that probably needs to be looked into, but it is a very difficult thing to study.
And what about alcohol? I mean, we have happy hours, or we have people who have no problems with alcohol and drink moderately, and then maybe you might have an alcoholic. What's the range of fertility health there?
The issue with alcohol actually is that it lowers testosterone levels, and therefore, as an effect of that, it will lower sperm counts, and you'll see impaired sperm motility, their ability to swim.
And is that while they're consuming, or is that a long-lasting effect?
Well, you know, once the alcohol is taken out of the system, the body has a remarkable ability to recover. So the effect on the hormones could be changed over a period of time.
So if you're trying to conceive, keep away from the alcohol during those days.
Well, yeah, moderation is the whole issue here, you know, not to excess.
Now, the next group I have, and some of these I also was not aware of, environmental exposures. I guess that can be bad for your health in any case if you're exposed to different chemicals. But I don't know if you had anything specific that's very harmful to fertility as far as environmental exposures are concerned?
Well, the government does have a website devoted to male reproductive hazards. And, you know,
is that under the Gov, or the... I'm trying to think of the website, but I guess if you just, for our audience, if they wanted to Google that.
Yeah, if they just put in male reproductive hazards, and it would probably, I think it's in the CDC where that's listed. I'll look and see if I can come up with that before but by the time we get to our question and answer period. But anyway, in general, the plastics, because they're synergistic with estrogen in the environment, and a lot of people are not aware that when women take birth control pills or they take hormone replacement therapy, the estrogen is pretty well excreted into the environment, and we have seen estrogen in the water to the point of seeing feminization of the fish. And so there's concern about that. And then you have the plastics, which also can have an estrogenic-like effect. There's pesticides. There's men who are in welding, dry cleaning fluid. Military radar has been associated. There's a whole
I hadn't heard that one. Military radar. That is interesting. I mean, the plastics one I think has kind of been made pretty well public. And these new bottles that are coming out, anything good to say about
I don't have any new information on
that. So no new studies yet. And then finally, I think for people trying to conceive, the lubricants can be an issue that maybe they're not aware of.
Yeah, because you've seen, I don't know if you've seen, even on TV, they've got commercials for lubricants, and the one that couples who are trying to conceive, if they choose to use one, should be called, it's called pre-seed.
Pre-seed.
Pre-seed. It is very analogous. It has a similar pH level and osmotic concentration to the semen, so it's healthy for the sperm, where a lot of those other lubricants are actually somewhat spermicidal.
Oh, that's not good for people trying to conceive. So pre-seed, that's a good tip. I do want to say to our audience, so we're about halfway through our material, and I know we're going a bit over time. So if you do have another commitment, we would be sorry to see you go, but we do have about half of our information still to present. So that was very interesting about men and a lot of things I hadn't heard before, and I hope that our audience learned something also for the men's presentation. And now we have the women. And after reading your articles again, it sounds like the menstrual cycle is a major marker of not just fertility health, but health in general. I'll just put up some of the main points that I gleaned from you. Age at first period, how can that affect a woman's health?
Well, women who have menarche late are the ones that we are more concerned about. Those that are 16 or so when they begin their menstrual cycles are of concern. Or conversely, the girl that starts very early on, before the age of 9, you would be, those are specific conditions. What we're more concerned about, and is more common, are menstrual cycle characteristics. There's a disorder called polycystic ovarian syndrome, which is tied to diabetes later in life, and it's a condition of insulin resistance. And many of those women do not have regular cycles. 60% of them are overweight. So, and these are the apples. They are not pear-shaped. They're apple-shaped more often.
And so that can be, if they're having wild menstrual cycles, that might be an indicator that they have this PCOS. Is that how you pronounce the acronym?
No, it's PCOS.
PCOS. And then you talk about it being a marker or risk factor for adverse reproductive health conditions. Is that in addition to the PCOS?
Yeah, these are women who have more difficulty becoming pregnant many times. Their ovulation doesn't happen as often. And then there are women who have the condition, but it's controlled, or their weight is normal, so they have less problems with conception. So when you have a woman who has PCOS, what you want to do is get her to get in normal weight range. That helps a lot, just that in and of itself.
Now, the last one here, you talk about menstrual cycle length, and I think that's kind of a topic unto itself. Is that right? So I made a separate slide here because you make sure to make a difference between what a regular cycle is and an irregular cycle, because it seems that it's misunderstood often.
Yeah, we have done such a great job of teaching women that 28-day cycles is it. And women, in fact, are irregularly irregular. And that means that there's a lot of variability to the menstrual cycle. As many as 40% of women can range more than 7 days, and that can be quite normal. And when I say range 7 days, what I mean is maybe the cycle is 24 days from beginning of one cycle to beginning of the next, and then the next cycle is 31 days. That's quite normal. And women have this idea that they should be 28 days long, and if you interview some women, they'll tell you, how often do your cycles come, and they say, well, it's usually in the second week of the month, but I'm always late. And what they're really describing to you is a cycle that's probably about 35 days long.
Which would be a regular normal.
Yes.
Well, that's good to know. So it seems like, I think where the misunderstanding comes in is that if someone does vary within a normal range, they consider that irregular.
That's the problem. And what we define in the healthcare world as irregular is having less than 9 cycles a year.
Okay. Yes, and I did note that, and I have a couple of slides that are about that. So what is significant about a large cycle variation? And these are the things that you had listed there. And this is a little different than having the very long cycles, but this would be, I guess, if they're having longer than 10 days. So maybe they have a 21-day cycle and then they have a 40-day cycle. Is that what you mean?
Yes. And those are the women that have a loss in their ability to reproduce, and then when they do get pregnant, they have a significantly higher rate of losing the baby at the embryonic stage.
So when they have these wild or large variations in the length of the cycle, what is it exactly, or do you know what causes the loss of the ability or the embryonic loss?
It's what you have there, the disturbances in ovulation, conception, implantation, and their ability to sustain a pregnancy, which can be a reflection of inappropriate levels of hormone.
I see. So it could be just regulating the hormones. And at that point, you would refer them to a specialist or something like that?
Yeah, I would. If I'm seeing a person in primary care who describes these long, irregular, or I'm not sorry, irregular, but this long variation of their cycles, I would refer them to an OBGYN.
Looked in more closely. And interestingly, then, you probably through your own observation see that it could be an indicator of later cardiovascular disease.
Correct. Women with the irregular cycles and this big variation are those women that are the ones that are going to get cardiovascular disease more often later in life.
That's certainly concerning. The other thing you spoke about earlier was the long cycles, and maybe you can pronounce that name for me.
Oh, that's oligomenorrhea.
Oligomenorrhea, okay.
Yes.
And from my understanding, that's when you have fewer than 9 cycles per year.
Right.
Is that correct? So if you have 12 months in a year, 9 would be quite long or indicate long cycles. And you had mentioned also already the predisposition then for PCOS. And you say it affects up to 10% of the population. That seems like quite a bit.
Yes, and we are hearing a lot more about this. And the women that have PCOS very acutely are those women who have excessive hair. They are, you know, a century ago that was the bearded lady.
Okay.
And these are women that...
so is it more testosterone? Is that what it is?
So they have an excessive amount of testosterone. And there's a chain of events with the hormones, which I won't go into because it's too difficult for a phone call to explain it all.
Sure.
But basically, because of the insulin resistance that they have higher androgen levels. And then because of the higher androgen levels, then their cycles are longer and they have more problems with the male pattern hair.
And what about, so they have these characteristics, but does it affect their, besides their fertility, does it affect their overall health? Are they considered healthy individuals?
Well, women with PCOS are the ones that, if you don't address the issue of the frequency of their cycles, these are women that are higher risk for endometrial cancer, for cardiovascular disease, for cholesterol issues.
Okay, so there are specific health issues to be aware of besides the fertility.
And the issue nowadays is that a common, quote, treatment for these women is to put them on birth control pills. But the problem, these women also get diabetes. So the problem with that is the pill will regulate their cycles, but it's a drug that alters your glucose metabolism. It's a drug that suppresses your ovulation. It increases your triglycerides. So when I'm teaching students, I don't teach them that I think that that this person is necessarily an appropriate candidate, because you're giving a drug that does exactly what the disorder does. So why would you do that? Why wouldn't you just treat the endocrinopathy? And that's one of the reasons I really like NFP, because it helps you get to the diagnosis better.
Well, speaking of the pill, you do mention a few of the birth control methods, and not so much what it does to their health, but when they're discontinuing them, how they come to fertility again. And it seemed like the pill and the injection were the biggest disturbances. Is that right?
Yeah, the injection is really a big disturbance. The Depo-Provera shot. is fertility can take actually up to 2 years to return, but most women after about 9 months or so it'll be returned, and and then the pill. The issue with the pill is that women are frequently advised that they can just go ahead and get pregnant after they come off birth control pills.
Right.
But what the issue is the cervical mucus is disrupted because it's been suppressed by the production of it has been suppressed by pills, and the luteal phase is abnormal in up to 30% of cycles coming off birth control pills. So I tell women I think they ought to wait about 3 cycles before they try to get pregnant so that you get through that period. And as an NFP teacher, I can tell you it takes about 6 cycles. There was for the mucus to return to normal.
Oh, okay.
And there was a good German study by a guy named Noth. It's G-N-O-T-H, Noth.
Okay.
And he documented that 90% of women return to normal fertility in 9 cycles off birth control pills.
So just somewhat less than a year. So for women going off the pill, that's something to consider, because I do think there's a bit of panic sometimes if they're not pregnant after 3, 4, 6 months. The other one, and the long-acting birth control methods that are quite in the news these days seem to have a rapid return to fertility.
Okay, so the way that was measured was by number of pregnancies. It was not that they studied the characteristics of the cycles when they discontinued the method.
Oh, okay, so you're saying something like with the luteal cycle or the mucus was not studied.
Yeah, that wasn't studied.
Okay.
It was just the ability to get pregnant afterwards. So I didn't have any recommendations to make for patients because I don't know that information.
I see. Well, one thing I was wondering, because the Implanon or the implant is a hormonal method, and to me it seems like it would be systemic, similar to the pill or the injection, and I was wondering, or I was curious, why or how can you return to fertility rapidly?
Well, actually the Implanon gives a lower dose of hormone than either the pill or the Depo-Provera shot.
Oh, I see. So it's just a matter of the hormone level being lower.
Right.
Okay.
Exactly.
All right. Well, that would answer my question, because I was curious about that. Like, why would this hormonal method not have the same effect? So as with the men we talked about previously, the women have their own set of lifestyle factors that seem to affect their fertility, although they're very similar. And here we have almost the same as the men, except for sleep. I'm curious how sleep can affect a woman's fertility.
Well, that was another part of my dissertation, that I found that there are vulnerable women to the exposure to light at night. And this dates back to the 60s. And in the 60s they tried putting a table lamp at a bedside, and they were going to develop it as a method of birth control. And so you have a hormone that induces sleep called melatonin.
Right.
And melatonin is actually found in the follicular fluid that's around the egg. And so it is a hormone that interacts to enhance the production of estrogen, of FSH, LH, and progesterone. So it's intimately involved in ovulation. And so women, there are not all women, but we as an industrial society think that light at night is not harmful, but for certain people it is. And so the studies demonstrate that if you use an alarm clock that has the red light, that's not going to have an effect, and that your bedroom should be, what I tell people is, hotel room dark, and that you shouldn't be able to see a picture on the wall. It should be that dark. People do not need night lights at night. They just don't.
Well, that's good to know. I think I'll have to go examine my own room. I think I got a few little blinking things that are maybe disturbing.
And you'll find that you sleep better. The blue and green alarm clocks, we are spectrally sensitive, and people are more sensitive to those.
What about stress? I get a lot of inquiries from women asking how stress may be delaying them to get pregnant or changing their menstrual cycles. Is that true, or is that
Yeah,
just
that's
individual?
true.
That is? Okay.
That's true. Women who get, the first thing is we live in such an instant society that I've encountered women who, when they decide they want to become pregnant, they want it to happen the first cycle of trying. And they're very stressed about waiting 2 or 3 or 4 or 5 cycles. But the fact is that in a 12-month study done with Marquette method, I think we had 87% of the women got pregnant in a year. So it is the tincture of time in terms of trying to conceive that women need, and when their stress level goes up about that, it's not helpful. And so that's one of those things that working with couples, it's like, this might be in God's time, it might not be in yours. You can do a few things, but and so then stress of job and stress in buying a house or financial or whatever, acute stresses can have a profound impact on a menstrual cycle. They can delay ovulation. Now, in my 16 years or so of teaching NFP, I've seen stress cycles, but I haven't seen that many. From acute stress, it's more chronic stress is probably more of an issue than acute stress is.
So acute stress, you might have one period that's off, but it would return, perhaps.
Yeah, it can shorten or lengthen a menstrual cycle, and really, when I'm working with couples, I'm talking to them about lifestyle in terms of, do you have a prayer life? Do you exercise? Do you ever meditate? How do you sleep? That you do kind of a stress questionnaire with them.
So then they can identify the things that they might be able to modify.
That would be right.
We are, again, as I mentioned, we're going a bit over, so we're almost to the end of the information. So if any of our audience needs to depart, we would sorry to see you go, but we have a few more interesting things to talk about. As with the men, the substances again, how are they any more unique for women than for men?
No, it's relatively the same, except I don't think there's any information that caffeine really harms the menstrual cycle. So that would be a little bit different.
Okay, for the cappuccino lovers, that's a good good news.
We've tried a lot to demonstrate the negative effects of caffeine, but really that's a thing that in moderation, should be it should be fine. So.
Okay. Well, the final thing that was interesting, so we have a couple of slides on this, is diet, and both for men and for women. And what I feel like I've got from you is that a balanced diet with maybe a few more indicators about what kind of fats to intake is not just a good fertility diet, but a good overall healthy diet.
Right.
But this interesting thing about the fats for hormone regulation and the whole dairy, maybe you would comment on that for us.
Well, first of all, the audience needs to know that this was developed by Chavarro, who's a Harvard researcher, and he used the Nurses' Health Study, which was a huge number of nurses that participated, and he looked at women who, the diet of women who were able to conceive versus the diet of women who were not able to. And in working with couples, nowadays people tend to think that low fat is good, but a person needs a certain amount of fat in their diet in order to make hormones. And that's the way I say it to my patients, that you need that. And so Chavarro's studies demonstrated that women who conceived more readily are those that consumed whole dairy. And then he has a nice explanation of how that relates to cholesterol and how that relates to hormone production.
Well, that is certainly interesting because, we're always told if you drink whole milk, go to 2%. If you drink 2%, go to 1%, et cetera, et cetera. But you're saying...
Well, I think it's because we're so worried about obesity, but actually we do need some whole fats in our diet. And so, the recommendation, and women just really hate hearing that they should be eating an ice cream a day or
I don't hate hearing
whole milk.
Give me that ice cream.
That's really a task for them. Anyway, so sometimes working with women means you need to get them to gain some weight if they're on the borderline of too low of a BMI.
Now, for the men, you have a different kind of fat warning or information.
Trans fats actually will be in the semen if a man's consuming too much trans fat. And I was pretty surprised. Again, this was an article by Chavarro, and I was simply amazed by that. I think we're all seeing the warnings on trans fats, and basically I just don't think that we should believe that people can do better than nature can in terms of, if you're going to consume butter, it's healthier, but you need to modify your portion. And so we taught for years and years that eggs were bad. Now eggs are not bad. They're good. And as an OB person, I always told pregnant women to eat eggs because they have all 21 amino acids in them and they're a perfect protein.
Oh, well, that's all very good information. Now, back to the trans fat, though, for the semen, how does that affect fertility then? Are they not able to swim properly, or the effect?
Well, it is. It's not a good thing to have in your semen, and I have to say that I'm not quite remembering what particular effect it had on sperm. So I'm sorry.
No, that's quite all right. Well, we'll have to go Google that.
Yeah.
Well, thank you for sending me this chart, which I've included here on this slide, because I think this outlines the main points of the fertility diet. You're talking about Chavarro. I think that this is taken from that study. Is that correct?
Yes, and then for the men, the male portion, it's the optimal male diet.
Okay, so I see.
Yeah. And so it's fairly similar. Men should have a little bit less fat, but they both should have just a little less than 8% or 7% of their daily intake. And there you have the daily serving of full-fat dairy food, such as whole milk ice cream or cheddar cheese. And then there's a number of both the avoiding the trans fats, and then the oils, the types of oils, getting them to drink water instead of soda, popcorn instead of chips is a healthier option. And then if they slow their carb, which means that you do the slowly digested type of carb, rich in fiber, and that's the whole grains, the whole grain pastas, beans, vegetables, and whole fruit. That makes up, it's more a Mediterranean kind of diet, actually.
Yeah, I was going to say, it sounds like a lot of what you hear for general health, and not just fertility. Well, I will say that we have come to the end of the information that you outlined in at least the articles that are available to read. Now, I think we do have a few questions. That's the end of our presentation. A couple of questions came in before the webinar, and I think we have a couple that have come in during. One that I got the other day per email, which isn't exactly about fertility health, but it's about getting pregnant, and this is actually a question that we get, or I get as a healthcare or client services person. The woman asks, I hear that it is best to have sex every other day to increase chances of pregnancy, possibly so that the man can replenish his supply. What is the current thought on this?
I think it varies by NFP methods. The two most fertile days of the menstrual cycle are the 2 days prior to ovulation, and then the day of ovulation is a fertile day, and that was demonstrated. So probably on those days they should be having intercourse every day. Maybe in the preceding periods you would want to have it a little less often, but definitely on those days.
Well, and I think there was some wisdom, and it's probably a little bit old now, but I even had some friends and acquaintances that were told just have sex every day, and without targeting much, oh, you'll be pregnant within a year. So it seemed like kind of a waste of time, and maybe increased frustration of the couple if they weren't getting pregnant. But you're saying that every day during the fertile days.
Yeah, I think it's fine.
And So following that recommendation, how long would a woman typically expect or wait to conceive?
Well, if we call that fertility-focused intercourse,
Mm-hmm.
and your rate of spotting problems, if you're having fertility-focused intercourse and you aren't pregnant in about 6 cycles, I would probably seek some care.
Okay.
But if it's just at random, then a year is the definition.
Okay, let's see. We have another question here. Let's see. It just came in a little bit ago. I am 43 years old, and I get my period every 14 to 18 days. So that must be short cycle. I eat well, have 14% body fat, and in general good health. I was prescribed the pill to regulate my cycle, but the side effects are too negative for me. How can I approach my OB to tell her that I don't think this is correct treatment for me? And she's saying the OB is adamant that the pill is the right course.
Then she might want to seek somebody else, get another opinion.
Mm-hmm.
And she might want to seek somebody that is in NFP care, because they would probably approach that issue a little bit differently. There's other things to be looked into, like, has her thyroid been checked? There's other medical things that should be evaluated when you have menstrual cycles coming that often.
Right, so it's not just trying to patch up to regulate the cycle, but maybe get to the root of why it's irregular.
Right, exactly.
We have another question. We do sometimes get this question too at our information email. Not to do with fertility health per se, but are there any sexual positions to help sperm implant the egg in order to conceive? I mean, from what I've heard, the position doesn't matter so much. Is that right?
Yeah, and I understand that to be true also. Mm-hmm. The position doesn't really matter.
Okay. Let's see. We have another one about STIs. Can you please comment about how an STI affects a woman's fertility?
Well, if a woman gets a sexually transmitted infection, if it's particular to chlamydia or gonorrhea, there can be infection of the tubes, and or she can get pelvic inflammatory disease, and there can be scarring there that will prevent her from getting pregnant.
So that seems pretty logical, that if you have blockages or that kind of thing, it would just be hard to mechanically get the sperm and the egg together.
That's right.
Okay, I don't think we have any other questions. There might be some coming in, but I actually had one of my own. Again, for our audience, we're now at 50 minutes. If you need to go on to other activities, please feel free to leave us. But I did want to ask Dr. Barron something, which is back in April, the CDC came out with some issues as a guideline for family planning consultation, and I don't know if I was just wondering if you had seen them or were aware of them and had any comments. And the reason I'm asking you is it seems like they are recommending a lot of the things that you have spoken about in your articles, which, for example, are making sure to provide preconception counseling to boost both maternal and paternal health for better outcomes. Another thing that in the guidelines that they're emphasizing is to have a client-centered approach. So, for example, the woman who just earlier said her OB only wanted her to be on the pill for a resolution, that it would be more perhaps discussed, give and take, what works better with the client's lifestyle, or maybe just to figure out their preferences or their own lifestyle, try to get things that, do you know what I'm saying?
Yes.
So right. I just wondered if you had seen that.
No, I haven't seen that guideline in particular, so I'm remiss about.
Well, that's fine. I know I know that you were probably wrapping
Spring
things
was
up
very
where
busy.
you were. Yes, spring was busy. Yeah. So I think that was back in April, and again, I would have to reread it. But I thought it was very interesting. It seems like a very sensitive, sensitive guidelines.
They came out with preconception healthcare guidelines, I think around 2005, the first time, and it was interesting because there were 10 recommendations and only one applied to the men.
Oh.
9 for women and 1 for men.
Wow.
So we have a little imbalance there in taking care of the guys.
Yeah, we got to get them to care more about themselves and get them some more info.
Yeah, obviously they're a very important part of this.
Okay. Well, Dr. Barron, unless there's anything more you'd like to add, we'll begin to wrap up the webinar. Was there something I missed or that maybe you wanted to comment on before we end here?
Well, the one thing that rounds out this whole preconception approach to patients is maybe you've encountered this if you've got NFP providers in particular, but when I'm talking to couples about the frequency of intercourse, I'm talking to them about the fact that the intercourse is not just love-giving, it's life-giving, and so they need to concentrate not just on one aspect or the other, because that increases the stress and is hard on the relationship. If they're so focused on getting pregnant that they're not having intercourse at other times during the cycle, that they need to take care of their relationship that way.
Well, that's very good advice, very practical advice. I'm glad you brought that up because that's one of those things that's sort of outside maybe a medical recommendation but can have a huge effect on a couple. Well, I want to thank our audience for listening in today, and I hope that if you have any questions or you think of anything after the webinar is over, that you please email us. You can send any questions to info@cyclebeads.com, and here I have it posted for you to look at. I would also like to thank you, my guest, Dr. Mary Barron, for taking the time to be with us today. This is Ann Mullen from Cycle Technologies, again with guest Dr. Mary Lee Barron, and we're saying goodbye. The webinar is now ending.
Thank you.
Thank you. Bye-bye.